and welcome back everyone. In the previous video we discussed about the esophageal atresia, tracheoesophageal fistula and esophageal varices. Now in this video we'll be discussing about achalasia, distal esophageal spasm and GERD, and also the complications related to GERD, that is esophagitis, strictures and Barrett esophagus. And in the next video we'll be covering all the remaining topics. So let's get started. Let's start with achalasia. Now, achalasia. This achalasia means when this lower esophagus, this lower esophageal sphincter is not able to relax. So for that, let's understand the normal physiology. Whenever we eat food, it goes to the stomach via esophagus. This lower esophageal sphincter opens, let the food pass into the stomach and then closes. But in this achalasia, what happens? There is failure of this lower esophageal sphincter to relax. And it is due to degeneration of inhibitory neurons in the mesenteric plexus of this esophageal wall. So what happens? Here, this lower esophageal sphincter is not able to relax, and because of this, on barium swallow, we can find bird beak appearance. It looks like a bird beak. And there are two types of achalasia, primary achalasia and secondary achalasia. The primary achalasia, it is idiopathic, but the secondary achalasia, it arises secondary to Chagas disease. Chagas disease you can remember easily as CHA in achalasia, and in Chagas again CHA. So it arises secondary to Chagas disease, or due to extraesophageal malignancies like gastric cancer. Now, for this achalasia, the manifestations are dysphagia, means difficulty swallowing. Other than dysphagia, there is regurgitation. Then retrosternal pain, weight loss, and also it is associated with increased risk of cancer. Now, what can be the diagnosis? So obviously, the mandatory finding include uncoordinated or absent peristalsis, obviously. And also the barium swallow shows dilated esophagus. Here you can see on barium swallow, it shows dilated esophagus. Now, what can be the treatment? Treatment can be surgery or endoscopic procedures. This was about achalasia. What is achalasia? It is when lower esophageal sphincter is not able to relax. Why? Due to degeneration of inhibitory neurons. Next is distal esophageal spasm. Distal esophageal spasm. What is this now? So this distal esophageal spasm, it is an esophageal motility disorder. It is an esophageal motility disorder. Now this distal esophageal spasm, also called as diffuse esophageal spasm, also known as diffuse esophageal spasm, it is characterized by repetitive, uncoordinated and non-progressive contraction waves. Of what? So of distal esophagus. So this distal esophageal spasm is motility disorder of esophagus, and on barium swallow we can see this corkscrew pattern. This corkscrew pattern. And what are the manifestations for this distal esophageal spasm? So manifestations are dysphagia, angina-like chest pain and regurgitation. This was all about distal esophageal spasm. Moving towards GERD, that is gastroesophageal reflux disease. Now, what is GERD? So in normal stomach, this lower esophageal sphincter is closed, which don't allow the stomach content to go into the esophagus back. But in this gastroesophageal reflux disease, this sphincter is not closed properly. And because of this, it allows stomach content to go back into esophagus. And in this, there is transient decrease in lower esophageal tone. And it is commonly present as heartburn, regurgitation, and dysphagia. And the heartburn, it is one of the most common manifestation of GERD. And it may also present as chronic cough and hoarseness. What can be the complications of GERD? So there are mainly three complications of GERD: erosive esophagitis, strictures, and Barrett esophagus. Let's discuss this one by one, all these complications. Starting with esophagitis. So esophagitis, it is inflammation of esophageal mucosa. Itis means inflammation. Whenever there is itis, it means inflammation. So esophagitis means inflammation of esophagus. Now there are different types of esophagitis. The first one is reflux esophagitis, also known as erosive esophagitis. This erosive esophagitis is the complication of GERD. But there are other esophagitis as well, like medication-induced esophagitis, eosinophilic esophagitis, infectious esophagitis, and corrosive esophagitis. Let's discuss them one by one. Starting with reflux or erosive esophagitis. So this reflux or erosive esophagitis, it is the complication of GERD. In this, there is reflux of gastric content into the lower esophagus. There is reflux of gastric content into the lower esophagus as we discussed in GERD. And this is most common type of esophagitis which arises secondary to GERD. Now the next one is medication-induced esophagitis. This medication-induced esophagitis is secondary to bisphosphonates, tetracyclines, NSAIDs, ferrous sulfate, and potassium chloride. Now, the next one is eosinophilic esophagitis. Now, this eosinophilic esophagitis, it is a chronic esophagitis and it is immune mediated. Immune mediated, why? Because in this eosinophil predominate. And this eosinophilic esophagitis, in this esophageal rings and linear furrows are seen on endoscopy. And it is associated with atopic disorders like asthma. Now the next one is infectious esophagitis. Now this infectious esophagitis it is associated with immune suppression. And it can be caused due to three reasons. The first one is candida. The second one is herpes simplex virus 1. And the third reason is cytomegalovirus. So in candida, here you can see there is white pseudomembranes formed. And it is multinucleated giant cells. And intranuclear eosinophilic bodies are also seen. And also the Cowdry A inclusion bodies are seen. The next is HSV1. So in this HSV1, there are punched out ulcers seen. Whereas in Candida, it was white pseudomembranes. And in cytomegalovirus, there is this linear ulcers seen. This is linear ulcers, you can see. And this is basophilic inclusions in nucleus and cytoplasm. And the next one is corrosive esophagitis. It is secondary to caustic ingestions. Now, moving towards the next pathology, that is strictures, esophageal strictures. So, strictures means narrowing or restriction of the lumen that leads to swallowing difficulties. Strictures, here you can see in picture, it is narrowing or restriction of the lumen, the esophageal lumen that leads to swallowing difficulties. Now, the next one is Barrett esophagus. Now, this Barrett esophagus, what is Barrett esophagus? So, it is a condition of metaplasia in which this normal squamous epithelium which is present in the esophagus, it is converted to columnar tissues. It is a pre-malignant change in response to lower esophageal stem cells to acidic stress. Now in this acidic stomach, this stomach is acidic. So what happens? The acid, it goes back into esophagus because it is a complication of GERD. So it goes back into esophagus and it start damaging the mucosa of what? Distal esophagus. And once it start damaging the mucosa, this distal esophagus will start responding back to this change. So what it will do? It will start converting its cells from normal squamous epithelium to columnar cells. And what type of columnar cells? So non-ciliated columnar epithelium. It was initially non-keratinized stratified squamous epithelium. Now it has changed to what? It has changed to non-ciliated columnar epithelium. And this is associated with the risk of what? Esophageal cancer, especially the adenocarcinoma. This was all about the second part of our playlist. I hope you liked the video. If you liked the video, do watch the last part of this playlist. Thank you.